meeting to discuss about interferon. And of course, I have to pay tribute to Dr. Silver and his pioneer work with this drug, in particular in polycythemia vera. Indeed, interferon is quite fascinating. We still don't really completely understand how it works. It was discovered many years ago. As you know, it's a kind of natural compound that is synthesized by our leukocyte, our white blood cells, when we are attacked by a virus, for example, in case of viral infections. And this compound has a broad mode of action, has several ways to protect us by directly killing abnormal cells, for example, but also by stimulating our defenses, our immune defenses, and restoring our immunity to get rid by our cells of abnormal cells. And it works for virus-infected cells, but also for tumor cells, just like in MPNs. Indeed, when Dr. Silver tried for the first time this drug in PV, it was a new drug and everybody was excited by its potential in cancer. It was quite disappointing in other diseases, however, still useful for patients with viral hepatitis, for example. But in MPNs, it remained very active. And we could show very recently that by chance, this drug has a specific action, when the JAK2 pathway is activated, which is obviously, as you know, a hallmark of MPNs in general, regardless of the presence of JAK2, CALA, or MPL mutation. So we're lucky to have this drug in the field for you and for our patients. So I will give you first some new information about the results we can achieve with this drug when it's used as the first-line treatment for MPN, and of course starting with polycythemia vera, and give you the final results of the trial that was conducted in Europe with ropeg interferon alpha, now almost 10 years ago. So you know, of course, this study, it included patients with so-called high-risk PV or in need of treatments, older than 60 years of age, or with a previous history of thrombosis. And the study had two parts. The PROUD PV study was for 1 year to compare head-to-head ropeg interferon to hydroxyurea to see it was as efficient as hydroxyurea to induce clinical hematological response. And then, after this point, patients could continue to be followed in the follow-up study, continuation PV or CONTI-PV, for 5 more years, and to see what happens on the longer term in terms of efficacy, but also of safety, because it was always a criticism against this drug that maybe it had many side effects, in particular in patients with hepatitis, because it's used at very high doses usually. That it's not the case, of course, in patients with MPN. So I will show you the results of this trial after a total of 6 years of follow-up, so quite the longest follow-up in a prospective randomized trial in PV. So as for the 6th year of treatment, the patients who were initially randomized not to receive ropeg interferon but hydroxyurea, indeed almost 90% of them remained on hydroxyurea, while some of them, 12%, switched to an interferon therapy after the first year of treatment. And you have here the doses, the median doses that were received. Just for information, the median dose of ropeg was around 500 microgram per month after the cumulative time of 6 years of follow-up. So first, these final results confirm the efficacy. You can see on this table first the rate of complete hematological response, or CHR, here. That was achieved in 54% of patients compared to 35% in the hydroxyurea arm. So more durable, good control of whole hematological parameters, because to achieve CHR, you have to have less than 45% hematocrit, but also normal leukocytes and also normal platelets. So a complete normal blood count. And of course, as you know, the main difference also is in terms of molecular response, or MR. You see that 66% of patients in the ropeg arm achieved such molecular response, decrease in the JAK2 allele burden compared to only less than 20% in the hydroxyurea arm. Dr. Silver showed you this slide. I show you the update on longer follow-up, just again to emphasize that you see here that both treatment arms started with this almost the same amount of JAK2 mutation, around 38%. With hydroxyurea, it's the black curve. After an initial decline, you see that these tend to rebound, and at the end of the day, the patients finish with the same or even higher JAK2 mutation than at the beginning. And in contrast, you see a continuous decline with ROPEG. This is the red curve, down to less than 10%. And it was, for example, 8% median after 5 years of treatment, compared to 44% in the hydroxyurea arm. Another way to express this profound impact on JAK2 mutant cells, so the selective effect of the drug against the abnormal cells compared to normal cells, you can see that after 6 years of treatment, more than 20% of patients treated with ROPEG had an allele burden that was very, very low, below 1%. Usually that's the limit of detection of the standard routine test, for example. It doesn't mean that it's completely eradicated. If you have a more sensitive assay, you will still find a small amount of JAK2 mutation, but at least very, very low level in 20%. This is achieved only in 1.4% of patients with hydroxyurea. So a very different impact on the JAK2 mutant cells. In terms of phlebotomy, you can see that after 3 years, almost 80% of patients treated with ROPEG were free of phlebotomy, and this remains stable over time, up to 6 years. So a very durable also efficacy in terms of getting rid of the phlebotomy. Of course, what is important is it safe? Okay, it's efficacious, but is it safe? And you can see, and we are pleased to see that the rate of thrombosis or of thrombotic events was indeed very low in both groups of treatment, hopefully less than 4% in both groups. So what we can say is that it's at least as efficient as hydroxyurea to protect from the risk of thrombotic events. And our hope, of course, is that by reducing the proportion of abnormal cells, you will reduce the risk of evolution on the long term to more aggressive stages of the disease, such as, for example, secondary myelofibrosis. So obviously the numbers are very small, but at least we are encouraged by these results showing that only 1 patient in the ROPEG treatment arm evolved to myelofibrosis compared to 2 patients in the control arm, and in addition, 2 additional patients in the control arm developed acute leukemia. So a difference maybe in terms of reducing the risk of progression of the disease. And this translates in a so-called event-free survival. If you accumulate in the same group the risk of having death, disease progression, or a thrombotic event, you can see that there was a great difference between patients receiving ROPEG interferon compared to those treated with the standard treatment, hydroxyurea mostly. In terms also of adverse events, again, interferon has a bad reputation, especially for patients receiving very high doses with a lot of side effects. You can see this table is very busy, but in fact, you see exactly the same number of adverse events in patients receiving ROPEG compared to hydroxyurea. That is supposed to be very well tolerated. So no difference, although the events were different. It's not the same type of adverse events with these 2 drugs. Obviously, they don't have the same profile, and that's why also everybody probably cannot receive interferon alpha because of this different profile. But what was reassuring also and very satisfactory with this new form of ROPEG interferon alpha compared to what we knew with standard interferon or pegylated interferon alpha 2A, the Pegasus, was a very low incidence of the so-called adverse drug reaction specific to interferon. You know that this drug induces, for example, depression. You can see here that only 1 patient developed such psychiatric adverse events. So it's very, very low rate compared to what we see with the other forms of interferon. Same for hypothyroidism. That is very frequent, or up to 20% of patients receiving interferon alpha will develop such an adverse events on the long term. Here you see very low incidence. So quite nice results in terms of efficacy. And also what we knew, of course, is that skin toxicity was much more pronounced in patients receiving the control treatment and hydroxyurea compared to interferon alpha. So altogether, this study, after 6 years now of prospective follow-up, comparing the ROPEG to standard treatment, showed a good quality of life, the low phlebotomy requirement even after 6 years of treatment, potentially the possibility to decrease the risk of disease progression, and higher probability of event-free survival compared to the standard treatment we have on the other hand. So, and this was also mentioned by Dr. Silver this morning. So this was for so-called high-risk patients. What about low-risk patients? What we call low-risk patients indeed are not such as low risk, because if you compare the risk of thrombotic events in patients with polycythemia vera younger than 60 years of age, it's higher than in the general population, although less than in high-risk PV, but they have a risk that is superior to develop myocardial infarction, stroke, etc., compared to the general population. So there's an increased risk compared to normal people. So it's not completely low-risk patients. Can we improve this treatment? This was the question of this very nice trial performed by our Italian colleagues. They randomized patients to receive either the reference treatment for this low-risk category, that is phlebotomy and low-dose aspirin, and they tested the addition of a low and fixed dose of ROPEG, 100 microgram every 2 weeks, which is a low dose, without taking into account, without adapting the dose to the response, etc. So the idea was, if we just add a small amount of interferon to the standard treatment, do we improve the outcome of patients? And indeed, it was the case. As Dr. Silver mentioned this morning, there was a difference after even 1 year of treatment. After 12 months only, they saw a significant difference in terms of hematocrit control, with the addition of ROPEG that was achieved in 84% of patients compared to 66% if you do only phlebotomy. And also, as it was mentioned again, the appearance of complications in patients with standard treatment, including one splenic vein thrombosis, for example. What was also very interesting is that when you phlebotomize your patient, you will reduce only the red blood cell compartment, but you will have no impact on leukocytes and no impact on thrombocytes. And even platelets usually increase over time with the appearance of iron deficiency that is induced by the repeated phlebotomies. So obviously here, by adding this cytoreductive drug on the standard treatment, you reduce the leukocyte count down to normal in most of these patients. That was not the case in the standard treatment. And the same for platelets. You see that the platelets were elevated, more between 600 and 800,000 at baseline, and remained stable on the standard treatment arm, while they normalized in the experimental arm. So you control not only the red blood cell compartment, that is important because it induces higher viscosity of the blood and may induce clots, but also the others, leukocytes, platelets, and we saw this morning that they could also be involved in the complications, including bleeding or thrombotic events. And lastly, of course, also very interesting, is that addition of interferon improved also the quality of life, with a diminution of more than 20% of the scores of quality of life compared to stability, or even an increase over 1 year or 2 years with the standard treatment. So interferon not only didn't negatively impact the quality of life of patients, but even improved it when it was measured by the questionnaires. And the third study I want to discuss with you today was shown at the last ASH meeting a couple of months ago by Dr. Gill from Hong Kong, where they are conducting a clinical trial with this ROPEG interferon in patients with myelofibrosis, prefibrotic and also overt myelofibrosis. So it showed interesting results. You see that overall they included prefibrotic MF, overt myelofibrosis, and myelofibrosis secondary to PV and ET, and you see that overall they saw a response in terms of hemoglobin, leukocytes, and platelets between 76 to 87% of patients, so good efficacy on the hematological parameters, with a good tolerance and few patients required dose reduction due to reduction of induction of anemia or thrombocytopenia, so well tolerated. So this was the three studies I wanted to show you with new results as first treatment for patients, but we know also that this drug, of course, can be useful once hydroxyurea is no longer tolerated, or if the disease is resistant, develops resistance to hydroxyurea. And this was the study by the MPD Research Consortium that showed that in both ET and PV patients, we could induce, who were already resistant or intolerant to hydroxyurea, nice overall response rate of 60% for PV, 69% in ET, including a nice proportion of complete responses in both diseases. So this drug is also obviously useful as a second-line therapy if you do not tolerate or if you develop resistance to hydroxyurea. I will briefly finish with combination therapy of interferon, and by showing you the final results of a study we conducted in France and that I showed just at ASH in December, that combined interferon alpha with Jakafi, ruxolitinib, in patients with myelofibrosis. The basic idea of this trial was that we have two drugs, one ruxolitinib that is very potent very quickly on the symptoms of the patients, on the spleen size, etc., but doesn't show such an impact, at least on the short term, on allele burden, for example, or fibrosis in the bone marrow. We don't see, or it requires 5-6 years of treatment to see a decrease in that. And on the other hand, we have interferon, where we showed consistently in PV and ET that it was able to reduce very quickly the mutant allele burden, but sometimes was not well tolerated. And the idea was to combine both drugs to improve the tolerance to interferon, because you know that this drug has a kind of pro-inflammatory activity at the beginning of treatment, and it was usually very poorly tolerated in patients with myelofibrosis who already have at baseline quite of inflammatory state. And interferon, usually you cannot use it, it's very poorly tolerated, and adding ruxolitinib could improve this tolerance and allow for giving sufficient dose of the drug to achieve the same results we see in PV, for example. So this study was including only patients with myelofibrosis of intermediate or high risk, and it was a first-line treatment because patients shouldn't have received neither ruxolitinib nor interferon alpha prior to study entry. So the idea was to combine both drugs from the beginning and not start with one and add the other if it doesn't work. This is the study design. So we started with ruxolitinib only for 2 weeks, just to improve the symptoms, for example, and achieve, for reduce the fever, the constitutional symptoms, and then start after 2 weeks of ruxolitinib alone, pegylated interferon alpha 2A in the trial. So it was Pegasus, not the raw peg. There were several endpoints. First, after 45 days, was to determine if the treatment was well tolerated by this parameter that is dose-limiting toxicity. Do we have any toxicity that prevents to continue the treatment or not? And the main objective was to assess the spleen response after 6 months, and patients were followed up to 12 months in the study. In addition, we had a series of biological studies that were done in these patients at the same time, just to try to see if we could define the patients by some biomarkers who benefit the most or could resist, or the disease could resist to this treatment. This included bone marrow biopsy at baseline and after 12 months of treatment, assessment of all the mutations at different time points during the treatment, some hematopoietic progenitor assay, measure of cytokines, inflammatory cytokines at baseline and at different time points, and also the study of the immune cells, the leukocytes, the T cell subtypes, to see if we see an increase in one or several of these effectors. So at the beginning, it was a so-called phase 1 study, just testing, because these were not new drugs, but the combination was new. So that's what we wanted to assess. And we included patients 3 by 3 at increasing doses of both drugs, starting with the lowest ones that were indeed 10 milligrams twice daily of ruxolitinib plus 45 micrograms of Pegasus, up to the maximum dose that was 22 times a day of ruxolitinib and 135 micrograms per week of Pegasus. Indeed, we had no toxicity at any of these doses, so we could increase little by little, and once we arrived to the highest doses, then we switched to the second part of the study that compared the two maximum doses that we could have in the trial. So a total of 18 plus 19 patients were enrolled, and I will show you the results on these patients. First, the primary objective was to see the reduction in the spleen size. This is a myelofibrosis trial, not polycythemia trial. And you see that 70% of patients experience more than 50% reduction by palpation of their splenomegaly. You remember that with ruxolitinib alone in the COMFORT-1 and COMFORT-2 study, it was around 30 to 40% of patients. So we almost double the rate of success. And this was durable because after 12 months, we had even a little bit more patients, 76% of them, achieving this endpoint. In terms of safety also, we were very pleased to see that there were very few high-grade toxicity. So the idea that ruxolitinib could allow to reduce the adverse events due to interferon seems to be true. Most adverse events were hematological, anemia, thrombocytopenia. Unfortunately, one patient died of acute leukemia transformation after 10 months on the study. And I will show you some results on these biomarkers. First of all, the bone marrow biopsy. Indeed, we were really pleased to see that in several of these patients, we had a clear improvement after only 12 months of the bone marrow biopsy that is only achievable with usually stem cell transplantation. You see that this, to get rid of myelofibrosis, either requires a long time, as Dr. Silver showed this morning, 5-6 years of treatment, and usually it works only with interferon alone in low-grade fibrosis, not when the grade of fibrosis is 3 or more in the bone marrow. So here, maybe we have a better and faster response in terms of normalization of bone marrow histopathology after only 12 months of treatment. I was talking about cytokines. You can see here each line is one individual patient, and each column is one of the cytokines. And when it's blue, it means that it decreased over time. You can see that the majority of patients experienced a decrease in their inflammation as measured by the level of these different cytokines after 12 months of treatment. That was quite nice. And in terms of molecular response, you can see here the evolution of the different mutations we had in these patients. These were, again, myelofibrosis patients, so they had not only JAK2, but some of them had CALR or MPL mutations, and many of them had the so-called additional mutations on top of the driver mutation. They accumulate a series of other mutations. What we saw, in fact, was a nice decrease on the JAK2 mutation from 84% to 56% after 12 months. That is in the range of what we see in PV and that we couldn't achieve before that in patients with myelofibrosis. We didn't have such a decrease in CALR mutation or MPL mutation, and also we were not really happy because we didn't see a nice decrease also in the additional mutation. So we could target JAK2, but it seems that the additional mutations may be more resistant to this type of treatment. And what we identified in this was the presence of I6L1 mutation. When a patient had also an I6L1 mutation, it impaired the ability of the treatment to reduce nicely the JAK2 mutation. Oops. I think that was supposed to be, not sure it was completely finished, but maybe. Anyway, most of the conclusions were there. Maybe the conclusion slide is just missing, saying that, in fact, we had this combination therapy that showed that we could achieve the same molecular and clinical responses at a proportion we see in patients with less severe disease, such as polycythemia vera, for example, in patients with myelofibrosis, that the addition of ruxolitinib improved the tolerance of interferon in these patients, and that maybe that could be a good solution in the future to combine both drugs, except, to allow to give a sufficient dose of interferon to achieve the objectives we want to see in these patients. And I don't remember the others, but I will answer the questions. So thank you very much.